Good evening, everyone, and welcome to MedStar Washington Hospital Center's live webcast on pelvic floor disorders. I'm Dr. Veronica Gomez-Lobo, Director of Pediatric and Adolescent OBGYN at MedStar Washington Hospital Center. Thank you for joining us. It's a fact, 1 in 3 women older than 45 suffers from a pelvic floor disorder, but surprisingly, younger women are not immune. Symptoms can be embarrassing and disrupt a woman's quality of life. Tonight you'll hear from 2 nationally known and respected physicians in the field of urogynecology, both with the National Center for Advanced Pelvic Surgery at MedStar Washington Hospital Center. Dr. Cheryl Iglesia is the Director of Female Pelvic Medicine and Reconstructive Surgery, and Dr. Andrew Sokol is the Associate Director of Minimally Invasive Surgery. We're also joined by a special guest, Tanya Blackstone, one of our patients, who at the tender age of 22 was diagnosed with urinary incontinence. Hear her story and understand that help is available. As you watch the webcast live via Windrose Media, feel free to submit your questions in the box on your screen. We want you to engage with us. We can also follow the conversation on Twitter at MedStarWHC and use the hashtag AskMedStar. Dr. Sokol, let's start with you. Can you tell us what is the pelvic floor and what are pelvic floor disorders?
Well, thanks, Veronica, and good evening, everyone. Let's start with talking about what the pelvic floor is. The pelvic floor is a set of muscles, connective tissues, and ligaments at the bottom part of the pelvis that support the bladder, the rectum, the vagina, and the uterus. They have several functions, the pelvic floor, supporting the organs of the pelvic floor. They help with sexual functioning. They also help maintain continence, but also allow the passage of urine and stool, and they also allow vaginal childbirth. Unfortunately, several things can go wrong with the pelvic floor, and that's the point of this webcast this evening. Several things include pelvic organ prolapse, or slippage of the organs out of place, bladder control issues, accidental bowel leakage, and then sexual dysfunction. Several things can lead to pelvic floor disorders. There are several risk factors. Most commonly age, although I should note that age is not that pelvic floor disorders are not a normal part of aging. Pregnancy and childbirth, particularly vaginal delivery, obesity, smoking, anything that increases the abdominal pressure chronically, or prior pelvic surgery. And it's really important to note that about 1 in 3 women experience a pelvic floor disorder in her lifetime. So let's talk first just about pelvic organ prolapse. Prolapse is the slippage of organs out of their normal position. The most common symptom of prolapse is a sensation of bulging. Sometimes people will see a protrusion. Sometimes people have low back pain, heaviness, or urinary or bowel dysfunction. In contrast, urinary incontinence is the accidental leakage of urine. There are 3 main types. Stress incontinence is leakage with physical activity like coughing, sneezing, or straining. Urgency incontinence is the type where you can't get your key in the door and get your pants down fast enough. You got to run to the bathroom. And then mixed urinary incontinence is a combination of both stress and urgency incontinence. It's important to know there are several treatments available for all of these pelvic floor disorders. They include both non-surgical and surgical treatments, behavioral therapies such as avoidance of over-drinking, the avoidance of caffeine and bladder irritants. There's pelvic floor physical therapy, and we have a whole network of pelvic floor physical therapists through National Rehab. Devices that can be placed into the vagina called pessaries to support the organs. And then we have many office-based procedures such as Botox for overactive bladder or minimally invasive surgeries, in and out, same-day surgeries or one-night surgeries that can fix these types of disorders.
Thank you, Andy. That was very instructive. We have a special guest in our studio who can talk about her patient experience. Tanya Blackstone is 37 years old and a mother of 3. For 15 years, Tanya suffered in silence until her bladder sling surgery earlier this year, performed by Dr. Iglesia. Tanya, can you tell us what you experienced and how you're doing today?
When I was 22, I had my first son, and ever since then, every time I sneeze, cough, laugh too hard, jumped, anything, I would have leakage. And I just thought it was normal. How many girls do you see walking down the street and you sneeze and you stop and cross your legs to sneeze? I thought it was normal. And it wasn't until about 2 years ago when one of my aunts, who's in her 60s, told me that she was having the surgery. And so I went to a urologist to see if there was something that I can do to fix my problem. And that's when I was referred to Dr. Iglesias.
And how are you doing today?
Oh my goodness, it's like I'm 21 again. I don't have a problem with coughing, sneezing, jumping. I actually went to a trampoline park a couple of weeks ago, and I was telling my girlfriend, I said I could never have done this before the surgery.
Yeah.
That's wonderful to hear. I want to remind everyone, submit your questions to us in the box on your screen. Dr. Iglesia, a viewer says, I hear so many negatives about having a sling procedure. Why was this the best treatment for Tanya? And what's the effectiveness of a sling?
Yeah. So a sling is basically a little strap, and it can be made of your own tissue or it can be made of synthetic mesh. It's the safer form of mesh that you wrap around the urethra, which is the opening of the bladder. And so this particular sling, yours has been around for over 17 years. It's actually considered the gold standard procedure for stress urinary incontinence. And in our hands, and in many, cure rates we can see up to 86%.
Wow, that's great.
Yeah.
Another question, what if somebody's had a complete hysterectomy and is morbidly obese? What are the chances of the surgery being successful? Dr. Sokol.
Right, so I mean, that's a great question, and there are a couple of risk factors. First, as we just briefly discussed earlier, hysterectomy alone may be a risk factor, but obesity can be as well. I mean, obviously, just good lifestyle modifications can be helpful, but there are still very effective treatments available, both surgical and non-surgical. We would always advise, of course, maintaining a normal body weight to decrease the intra-abdominal pressures, but there's still very successful options available.
Even if you're morbidly obese?
Even if you're morbidly obese.
Now we hear,
quite frankly, I mean, for some people, they get increased body mass and become obese because they can't exercise because they're leaking.
Oh, that's a good point.
So, it's a chicken and egg kind of thing, but we solve this problem. Now they're on the treadmill and the trampoline, and they can be more physically active.
That's great. Is mesh from sacral colpopexy safer than mesh from the TVT? And what is the safety risk with other mesh or other products today? Dr. Sokol.
Right, so there's a lot of confusion right now about mesh. And I should say all mesh is not created equally. Mesh is used in many types of surgery, hernia repairs. Slings are a very small piece of mesh. So the risk with a sling is only approximately 1%. Sacral colpopexy is a surgery that's done through the tummy to pull the vagina up to an area around the backbone. That's also considered to be the gold standard. All the FDA advisor, there's an FDA advisory about is about mesh kits. That's mesh placed through the vagina. But nowadays, even that has become much safer as the technology's changed quite a bit from some of the original studies.
Dr. Iglesia, I understand you've done some research in mesh. So what were the main problems that people were having with mesh?
Yeah, so I actually will disclose that I actually was on the panel that reviewed the vaginal mesh for prolapse. And so that's not the little strap. Those refer to sheets of mesh that are placed in through the vagina. And I should say that, a lot of the ones that were first developed are no longer available. And it may be that those first vaginal meshes that were used for prolapse were too heavy and too big. And the beautiful thing now is that we have smaller meshes that when used by the right surgeons in the right patients are safe and effective, and we have a registry to follow out, because what's most important is what the patient feels and her partner and what she thinks, not what we as surgeons or physicians think. And so the registry is designed to look at patient-centered outcomes. So
to look long-term.
And
Tanya, were you worried about having something put inside your body?
I actually asked Dr. Iglesias a lot of questions about my body rejecting it. And she assured me that the type of mesh that she was putting in, I should have little to no problems with. And I have not had any problems to this day, and it's been a few months now.
And I showed you the mesh, and I think did I show you the different, and I think that's very important because I see a lot of women who have had prior surgery and they don't know what's put in their body. I want to tell people that they should know what the product is, and do some little research just to make sure that ask your doctor how many times have you put this in and what kinds of complications you've seen. I think it's not inappropriate to try and ask a lot of questions, and I mean we like to allay your anxiety and give you as much information that we know.
Dr. Sokol, what kind of complications would you tell a patient before having this type of surgery that they could have?
Right, so I mean, as with any surgery, there are small risks. I should say that most of the surgeries, or almost all the surgery we do, is minimally invasive. So that doesn't mean that it's not surgery. So we do spend a lot of time discussing the risks. As with any surgery, there's small risks of bleeding or infection. We have standard ways of taking care of those problems. in particular, I think you may be discussing mesh. You know, there are certain patients who are good candidates for these types of devices, some who are not, and it's really our goal to choose the best surgery, fit the surgery to the patient, not fit the patient to the surgery.
So Dr.
But, you know,
Iglesia, what should a
sometimes-
patient be watching out for? They had this surgery, and what if something goes wrong? What kind of things should they be paying attention to? 'Cause
We get
don't
a
want
lot
to
of
wait
those
15
questions,
years for that. you know.
right? Because they look at the advertisements on TV, and then they're calling up, "Is that what you put in me?" Again, I think it's important to know what was put in. But you know, if you're not having any problems, then in general, there's no problem. The problems that you can have if you're having your partner, you know, during sexual relations is feeling the mesh. That can be a problem. If you're getting chronic bleeding or discharge, that can be a problem. Sometimes more difficulty with emptying the bladder can signal that you're having a problem. Or, you know.
And if I may
Sure.
add,
Yeah.
I mean, many of the surgeries we do don't involve any mesh. It's not true to say that we use mesh in all of our surgeries. We have many surgeries are done with just what's called native tissue repairs. So, you know, mesh is only used in a certain percentage of women and when it's deemed to be appropriate.
I see.
Yeah.
And Tanya, I understand you also had another procedure along with the sling?
Yes. I also had
The prolapse repair by the rectum, the rectocele.
Yes. So
Yeah.
I don't really know exactly what happened.
What were you?
No mesh,
Well,
no mesh by the
we'll
rectum.
ask Dr. Iglesia what she did next. But what were you feeling, and why did you know what was the sensation or the symptoms you were having?
Well, I was actually, you could actually see my bladder.
Oh, okay.
You could see my bladder. It was, I didn't know that that's what it was until the urologist showed me and referred me to Dr. Iglesias. And I had no idea. I had painful intercourse and, of course, the urinary incontinence. And, you know, I would never have known
So,
what
in
that
addition
was.
to the sling, you performed another surgery,
Right.
Dr. Iglesia?
So, it is not uncommon when you have one pelvic floor disorder that other pelvic floor disorders can coexist. And for women who have incontinence, 40% or so can also have the sagging organs. In her particular case, there was a little bit of a hernia of the bladder, which is called a cystocele, and the rectum as well. And then those can be repaired easily through the vagina with no mesh.
Oh, okay. We're getting some more questions. But first we want to talk about pelvic floor disorders that are associated with female sexual problems. You were just talking
wow,
about problems
yeah.
with sex with these type of problems. Dr. Iglesia, do you want to?
Well, it was a good segue, Ms. Blackstone. You know, there are 4 major types of female sexual dysfunction, and while male sexual dysfunction seems to get a lot of airtime right now, women's female sexual dysfunction is actually equally, if not more, common. Up to 43% of women can have a sexual dysfunction, and the 4 most common types are desire, arousal, orgasm, and pain. Now, of those, desire, low libido, is the most common problem, and that could be hormonally related. You know, certainly body image, relationship issues can and prolapse can affect this as well. So I feel that it's really important, you know, if your pelvic floor is bothering you in ways that are affecting your quality of life or your ability to have a good sex life, you know, see a doctor.
So if you have problems with your sex life, you should ask your doctor. We have another question.
Yeah.
Supposedly, something called the O shot helps women with sexual problems and may also help with incontinence. Please give your thoughts on this, Dr. Sokol.
I'll defer to the sexual function expert.
Okay.
on this one.
Dr. Iglesia?
This is kind of a pet peeve of mine. So this O shot, also called the G shot, this is where a little injection is placed along the anterior vaginal wall, maybe around the area where the G spot's supposed to be. And you know, women are paying hundreds, if not thousands of dollars for this type of cosmetic surgery, for which we really don't have a lot of evidence. So I really do think it's important that people understand what's bona fide and then what is out there that is maybe complementary, but we really don't have a lot of evidence for efficacy.
And how can a lay person figure out what's really bona fide versus
Yeah, well, I think
what's sort of hype or?
There's so much hype there right now with all the vaginal rejuvenation, laser vaginal rejuvenation, and women are paying a lot of money for cosmetics type of surgeries on the labia. And I really think it's important to educate yourself. I think seeing a specialist in female pelvic medicine, reconstructive surgery, board-certified gynecologist or urologist would help.
Dr. Sokol,
I think also, you know, really going onto reputable websites. So, you know, the American Urogynecologic Society has a patient portal, takethefloor.org.
There's
a lot
voices
of voices for pelvic floor disorders. Voices
so
for
educate
PFD.
yourself. Don't just go and spend a lot of money on something that
That's
might
right.
not
And then
work.
also, you know, I mean, especially if it's going to be something that costs a lot of money or, you know, is some type of an intervention, really seeking out someone who's got specialty training in that type of disorder.
That's right. So OBGYN is 4 years, but pelvic floor surgery training is another 3 years.
Yeah.
Another question, is it normal to expect continued or worsened incontinence after menopause? Dr. Sokol.
Right, so this is a great question, and this sort of is similar to, is it normal to have any of these issues with aging? The short answer is no. Aging does not result in urinary incontinence. Certainly it's a risk factor for worsening incontinence, but I would not say it's normal. Most women as they age do not suffer from these problems, and these things can be helped.
That's good. There's good news. What's the treatment for that's recommended for incontinence that's related to Parkinson's disease, Dr. Iglesia?
Okay, so Parkinson's disease, multiple sclerosis, stroke, spinal cord injury, a lot of these patients suffer from bladder problems because the wires get crossed. You know, your brain is telling you it's not a normal time to urinate, but your bladder has its own signals. And so it is very important that we get that treated and evaluated. Sometimes people don't empty well. Sometimes the bladder is emptying too much. The beautiful thing is that we have this bladder Botox injection, and you know, some of my Parkinson's and MS patients, that has been a game changer for them.
I see.
Yeah.
I see.
So you need to get this area of neurogenic bladder, and it has to be worked up, because if you're not emptying well, then doing something to tighten the sphincter or doing something that prevents, makes emptying harder is not a good thing.
Makes it worse.
So
Tanya, did you have any problems with that kind of sensation that you felt like you had to pee all the time, or that you lost your urine when you were trying to go to the bathroom, or only when you coughed and sneezed?
I only had issues when I coughed or sneezed, jumped, just stress incontinence.
Okay.
That didn't happen.
So of all the women that leak, about half of the women have that symptom of stress incontinence alone. About 30% have the urgency type, and another, you know, 30-40% have them both together.
And
as you get older, Veronica, the urgency actually predominates more.
gets worse.
Garden variety type
And can
leakage is
surgery
more.
make the urgency worse?
Well, so it is possible certain types of surgery could potentially worsen urgency. When we're talking about treating urinary leakage, it's understood that when we're talking about, say, a sling, that's just to treat the leaks with physical activity. The urgency is usually not treated surgically. There are certain things that can be done surgically, but that's usually treated medically. So it's possible, but I would say it's uncommon.
But if you have a mixed component, so if you had the stress with laugh, cough, and sneeze, you still have an 86% chance of fixing that stress component, and I would say about a 30% chance of actually fixing the urgency as well,
even with the surgery.
Speaking. But you don't go into the surgery thinking about that. Most people, we warn that that the urgency can persist. In the majority, probably 66%, and it might even be possible that the urgency gets worse. So that's why we have the alternative treatments.
So we have another question, which I think is a very interesting question. Does an autoimmune disease increase the likelihood of rejecting the mesh, Dr. Sokol?
Yeah, so
if you have lupus or
this is a
something
great
like that.
question. We're very, the short answer would be yes. So we're very careful about using synthetic materials in people who have chronic disorders such as diabetes or autoimmune disorders. I mean, it's, like I said before, we have to look at the broad picture of the patient's health and her goals and her wishes. I wouldn't say it's always true that someone with an autoimmune disorder would reject a mesh. It's very uncommon, actually, but there are lots of alternatives, and there are, obviously if there are conditions under control, then not necessarily. But if someone's got uncontrolled disease, that might be a risk, that we're a choice to use a native tissue repair.
Be more careful.
We have done slings and used synthetic mesh in patients who are renal transplant patients. It's interesting because you put a kidney in and now they can make urine again, and now they remember that they're leaking.
Right.
And in patients who have arthritis and are some of these immunosuppressant type of drugs. And we just sort of work with their rheumatologist or something to try and get the lowest dose possible around the time of surgery, so before and after, so that you can kind of decrease that risk, the immediate risk for infection and rejection.
I see.
But it's not you know, it's not a complete contraindication.
And you mentioned infection, and the next question is actually about bladder infection. Why can bladder infection be so difficult to diagnose, and why are some difficult to clear? Dr. Sokol.
Yeah, so first off, bladder infections, really what that means is there's bacteria growing in the bladder and symptoms. So many women have symptoms of urgency and frequency, and it's not actually a bladder infection. So we see women who come in all the time and they've been struggling with urgency frequency syndrome where they're running to the bathroom all the time. So the real goal is first to make sure that it's actually urinary tract infections. There's certain things that can cause urinary tract infections, most commonly, of course, just sexual intercourse, but also things like kidney stones, anomalies or abnormalities of the urinary tract. So those things can be evaluated by a specialist as well.
So
you know
it
what?
sounds,
I would put plug in for local estrogen.
Oh.
I mean, we have a slide here about vaginal lubricants, but let me tell you, ladies and gentlemen, if you're listening, dry vaginas can lead to urinary tract infections. And we know when the vagina is dry and the estrogen levels are low, then the bad bacteria populate, and the good bacteria are kind of crowded out. So keeping a little bit of local estrogen, even though I'm not a big fan of systemic hormones, local estrogen will keep the pH good balance of the bacteria and actually can prevent urinary tract infection. So that's something to consider.
And so what I'm hearing too is that you have to prove it's a urinary tract infection.
For
you
sure.
should probably check. Did you, Tanya, were you ever checked for urinary tract infections when you were losing urine?
Before I actually did have multiple urinary tract infections before I had my son, but then it just seemed to go away, and then the incontinence started after.
Is there a relationship between those two?
Well,
Dr.
certainly there can be
Iglesia?
a relationship between urinary urgency incontinence and bladder infections. Also, of course, if you're leaking urine and you're not frequently changing pads, there's an increased risk that the pads, which don't breathe very well, can trap bacteria. The same thing can happen with accidental bowel leakage. So if there's bowel leakage, you're more likely to get a urinary
But if
infection.
the bladder's dropped, Veronica, and it's starting to sag and you're not emptying completely, that's a risk factor.
That's a risk factor too.
And that could be a sign. And let me tell you, it's not just good to examine while you're lying down. If you really want to see what's going on, stand up, because gravity will take place. And sometimes you have to stand up and cough, and you see the leakage and see the sagging organs.
We have a different question. I have recurrent prolapse after a previous prolapse surgery. Am I at higher risk of failing another surgery? Dr. Sokol.
So this is an excellent question. About half of the patients, 30 to 50% of the patients that we see have had prior surgery, so or even higher. I mean, the first surgery should be the best chance, but not all surgeries are the same. So it's unclear it depends on what the first surgery was and if it was done by a subspecialist. I would say if they're seen by a subspecialist and they get a standard surgery, that's standard of care. It's not necessarily the case. And we would adapt the surgery. So if someone had one type of surgery, we may choose a different surgery that may be more effective.
So depending on who did the first surgery, the second surgery might be more successful or less successful?
I think it depends on the approach, because sometimes they do, like you have prolapse and all they do is remove the uterus and they don't address the bladder and they don't address the rectum and they don't address the leakage. Well, that woman's doomed. So it kind of depends on the whole workup and the whole approach, so you can figure out how to tailor the right surgery to minimize the risk. Because statistically speaking, 30% of women who do surgery, who undergo surgery, have to have another surgery within 10 years.
So it's not that uncommon.
But I'm wondering whether or not there's a failure to correctly diagnose.
To treat the right thing
and I think
the first time.
that's 30% numbers is changing quite a bit. When you look at we're not going to get into the study, of course, but I think the point is there's hope. The cure rates are still excellent. There are many things that can be done even for recurrent prolapse.
Perfect. That's great news. Here, I think I heard you talk about Botox, Dr. Iglesia. What pelvic floor disorders does Botox treat, and how long does it last for?
Okay, so Botox is FDA approved, which is onabotulinum toxin A, is FDA approved for overactive bladder or urge incontinence. And in general, that's an office procedure where we place a lighted telescope and place a few injections around the bladder. It takes 3 to 10 days for that to take effect, and can last anywhere from 3 to 9 months. And there was a big trial in the New England Journal of Medicine, and I'm on the Pelvic Floor Disorders Network as an advisory board chair, and this was a landmark trial last year that showed that both the medications and Botox were equally effective. However, there was more cure with the Botox.
I see.
And that has been really, really important because these medications have side effects like dry mouth and constipation, sometimes mental cloudiness.
I see.
And Botox is just local.
And are there any risks to the Botox injection?
Yeah.
Dr.
Yeah,
Sokol?
so I mean, as with all interventions, there are small risks, but the most common risks are fairly easy to take care of. There's a common risk would be urinary tract infection, but we always give antibiotics to prevent that problem. There's a small risk of the Botox working too well so that the bladder is not emptying perfectly, and there's about a 5% chance that someone could end up in a situation where they're having a difficulty emptying the bladder, and then we can manage that.
It works too well.
And do you ever, you mentioned cure, do you ever just do one Botox shot and it wears out in 9 months and then you never need to do it again?
No, those people are generally calling me on the phone. I need to set up another Botox injection because it's worn off. And they know right away.
It wears off.
But
when it wears off, the spasms of the bladder start again.
So how Botox works is a local injection kind of paralyzes the bladder because it prevents the release of the neurotransmitter, which is acetylcholine, but the bladder can't contract.
But Botox injections can be repeated. There's a recent study showing that there's no adverse effects, so it's touched up.
So having more Botox doesn't make things worse.
It's a 5-10 minute procedure without the side effects of taking medications.
I see.
So it's good to have an armamentarium.
You mentioned bladder. We talked a little bit about bladder infections, but there's a question: are bladder infections more common with prolapse? I think you mentioned that with a prolapse, the urine sort of sits there.
I think the reason why bladder infections can be more common is due to what's called urinary stasis. The fact that you're going around with your bladder, your gas tank half full all the time because you're not emptying, so the bladder can get stale. And we've seen women who have significant prolapse and the bladder is kind of kinked off, and then they develop multiple stones in there and multiple infections.
Right.
So,
And just to clarify, because I'm not sure we covered, but when the vagina relaxes, it can block the ability to urinate by bending the tube you urinate through like a garden hose.
I see.
Same thing can happen for the bowels, essentially.
gets kinked off.
Actually, that's the next question. And Tanya, you mentioned that there was a problem with prolapse of the rectum also. Were you having problems with constipation or anything like that? No. Okay, that's great.
Yeah.
It says the question was, can prolapse cause constipation?
Right. So, yes.
Okay.
Now, with constipation, it's a little bit of the chicken or the egg. In certain women, the bowel gets trapped in the bulge, and then they can press the bulge, and the bowel comes out. But in other women who are chronically straining, they could actually develop prolapse. So there are many causes of constipation. Some of them are not related to prolapse. Some of them are functional. Some of them are dietary. Some of them have, bowel movement issues throughout the whole GI tract. Sometimes, yes.
Even in my experience, a lot of people have prolapse. That's a very common complaint.
But if you feel like you're constipated and you can't get it out, and you actually have to insert your finger into the vagina to push the bowel out the right hole, then you probably do have a prolapse.
Right, and that's when surgery can help.
We talked a little bit about estrogen before. You mentioned estrogen with sexual function.
Yeah.
Do you prefer Premarin or bioidentical hormones? And are vaginal estrogens safe if you've had blood clots? Those are great questions.
Very common questions. I prefer FDA formulations, and I get this not uncommonly that women are going to these compounding pharmacies, and they have the estrogen and the testosterone, and it's very hard because that's not regulated to know how much. So Premarin is a conjugated estrogen, and estrase is a bioidentical type of estradiol. I think that they can be used safely in the vagina if you have a uterus, or if you don't have a uterus, because the dosage is so low. There's also rings and tablets that are also FDA approved. So we can.
Are they safe with blood clots?
Well, I think if someone's had a history of blood clots, obviously, oftentimes they're on anticoagulation or blood thinners.
I see.
We would usually, of course, clear it with their doctor. We're not talking about hormone replacement therapy by mouth. We're talking about local estrogens, which have a very low systemic absorption. So it's mostly just local. But of course, we would always clear that with the physician.
So if they're on a blood thinner and they're getting a very low dose, we feel that that's very safe in general. Now, some patients go and want to have compounded, biological equal estrogens. What are your thoughts on that?
It's just, and the American College of OBGYN has a committee opinion on this, that all of the urinary saliva testing, we cannot follow that. There are many things that can, in your diet, the circadian rhythms, that can affect these levels, and so titrating that and using the creams. The problem is it's just unregulated.
I see.
And we really don't know how safe this is.
It's better to know what's been studied.
And at least we have some
and I agree with that.
some safety and effectiveness data for that. And you know, and some women just don't want to use estrogen.
Let
they have
me
a
go
history.
to the next question, which is totally different, but I think it's something that's really important, which is sort of the non-surgical part. How can the pelvic floor be strengthened, and at what point are the exercises not effective? Or are they useful, not useful?
Yeah.
Did you ever do pelvic floor exercises?
Kegels?
Yes, Kegels. That is actually recommended after you have children and actually during pregnancy. But I did Kegels for years and they just didn't work. And I don't know. I didn't know that I was doing them so well until I went to the urologist and he said, "Oh, your Kegels are."
So I can feel this. I mean, pelvic floor strengthening exercises can actually be very useful for certain conditions. And I think what you're referring to, Tanya, is that once you've got a certain degree of relaxation, it can't reverse the relaxation. What it can do is help the symptoms, and what it's really effective for is actually preventing urinary leakage from urgency. You can help retrain the bladder, and it's really an excellent way to help strengthen the muscles that control continence. So for some people with, say, mild stress incontinence, with fluid management and pelvic floor strengthening, sometimes they can get their symptoms to a point where they're not particularly bothersome and they don't require surgery.
So did someone teach you how to do the Kegels, or you just figured it out on yourself?
You kind of figure it out.
On your own?
Right, but we have a whole network of female pelvic floor physical therapists, standard ways that we teach it, and we have handouts in the office. So it is standardized.
But there was a question, where was the point of no return? So you can keep doing these Kegels till the cow come home, but you know, the issue is the muscles are good, but the ligaments are shot. You know, if the ligaments that support the urethra, the ligaments that support the bladder, you know, and
They're just
and
too
the uterus,
stretched out, so the muscles
you
don't
can do
make a difference.
It's not going to. You got to get that back in place.
So we've got one last question, 'cause we only have 1 minute,
It's went
I think.
so fast.
Will native tissue repairs last long term?
Yeah, so I mean, we have excellent data on native tissue repairs out several years, 5 to 7 years for some of the repairs, and it's hard to follow people out long term for studies, but generally speaking, yes, we have excellent long-term outcomes for native tissue repairs, and as I said before, there are many surgeries we do. They do not all involve mesh.
And can you just explain what native tissues
So
are?
native
Some
tissue is
people
when
might
you
not
use
understand.
stitches and your own tissues, so tightening muscles, pulling things back up and stitching them into place. And actually, most standard surgeries are native tissue repairs.
Okay.
Mesh is only used in certain situations.
Okay.
And the outcomes are excellent.
Well, we're almost done. Any final thoughts, Dr. Iglesia and Dr. Sokol?
Well, I want to thank people for tuning in. And I know there's people in the Washington region and around the country. And you know, if you think you may have a problem, talk to your gynecologist, your urologist, but also be aware that there are specialists. There are female pelvic medicine and reconstructive surgery specialists. And if you need to find one near you, you can go to the American Urogynecological Society website. And there is a voicesforpfd.org that you can check out and find a urogynecologist near you.
And MedStar itself has now MedStar South, which is soon to be 5 fellowship-trained pelvic reconstructive surgeons plus 2 now at Franklin Square. So we've got a big network.
Thank you, Cheryl, and thank you, Andy, and thank you so much, Tanya, for coming. We want to thank everyone for joining us this evening. If you have further questions, we invite you to schedule a patient consultation with one of our physicians at the National Center for Advanced Pelvic Surgery by calling 202-877-DOCS or 202-877-3627. The website address is medstarwashington.org/urogynecology. A reminder that this webcast has been recorded so that you can watch it again on the MedStar Washington Hospital Center website or on our Facebook page. I want to thank our special guest, as I just did, Tanya Blackstone, for sharing her story, and thank you, Dr. Sokol and Dr. Iglesia, for sharing your expertise tonight.
Our pleasure.
I'm Dr. Veronica Gomez-Lobo. Good night.